Okay, everyone, welcome back. Uh, if you all remember, this week's case is a 62-year-old African American female. She presented a lot more acutely with some severe left lower quadrant pain beginning 48 hours ago. You can see here the case just for your memory to remind you. She had some nausea and vomiting. And really, when I see this type of a history, when I'm seeing the words severe, when I'm seeing the words acute onset, those are things that are tipping me off that maybe this is more of a acute emergent case versus something that's more chronic where I have more time to uh, come up with my differential diagnosis and workup steps. So anyways, we remember she didn't have any past medical abdominal history, but she had some history of diabetes and hypertension, history of smoking. And then we get back down to our exam. And if we look at our abdominal exam down here, we see that she had a palpable tender mass in her left lower quadrant that was about 2 by 2 centimeters and some tenderness and guarding in the left lower quadrant. No rigidity, non-distended. These are important things to note in your chart. And she had all of the special tests were negative, thinking about appendicitis. If we look at her vital signs, her blood pressure was low normal, but still in the normal range. Heart rate was mildly elevated, but she has a fever, so that makes sense if we think about elevation and pulse does tend to happen with a temperature, and she had a temperature of 100.2. And so when we think about red flags, red flags, or things that are more acute and emergent, those are some things that pop out to me. If you made it to the end of the case, which you should have at this point, diverticulitis is probably where you ended up given our imaging and our findings. And so this up-to-date article is a good starting point for some clinical features of diverticulitis. And if you remember, diverticulosis is a disease that's not acute in nature, and people can have diverticulosis and not need urgent treatment or workup. Diverticulitis is the inflammation or infection most of the time of the diverticula that occur. And so that is in a more acute condition, as we can see with our patient's presentation. And so if we think of some acute complications about diverticulitis, abscess, which our patient did have an abscess, obstruction, fistula, and perforation. So things that can be pretty serious, and they can get pretty serious pretty quick. When we look at lab findings, you can see CRP being elevated. We didn't get a CRP on our patient because it's not specific. It just means inflammation, but mild leukocytosis. And so we did obtain a CBC. And I'll talk about some labs that were obtained. And then we'll go into kind of imaging and next steps of workup. But this is a helpful overview of some clinical features as well as what are your complications that you're watching out for. So if we, our favorite resource or my favorite resource for radiology is the ACR appropriateness criteria. And so here it shows if we are suspecting diverticulitis or if we have a patient presenting with left lower quadrant abdominal pain, our ideal imaging would be a CT abdomen pelvis with IV contrast. Now make sure it's important that you include CT abdomen and pelvis, because if you just include the CT abdomen, you are likely going to miss things like the appendix and the left lower quadrant itself, because they won't actually CT low enough to see those structures. So really important that you put both of those structures in when you're ordering imaging for patients if you're concerned for diverticulitis. As we see here too, even if you had a suspected complication of diverticulitis, CT abdomen and pelvis with IV contrast is the preferred imaging study. Anytime I'm thinking acute abdomen, so appendicitis, diverticulitis, any acute abdominal process that might need surgery, I am leaning towards CT. And you'll see that in an emergency setting. Even if an ultrasound could also show something like an appendicitis, they'll often jump straight to CT because it's quick and it's more accurate. So that's the imaging that we used. Some interesting things about labs though. You don't actually need lab studies to diagnose someone with diverticulitis. You can actually diagnose them based on clinical assumption and history and physical exam. But there's some important labs that you can obtain, and you can obtain relatively quickly. So we got a CBC, which showed a leukocytosis. So it showed our white blood cells were elevated with a left shift. This you could also see in an elderly patient, and I've had this before, no left shift and a normal white blood cell count. So something to keep in mind. It's also important if you had a patient like ours who's complaining of some bloody stool, hematopoiesia, to get a hemoglobin level to make sure that they're not anemic and don't need any any blood products or aren't no concerns for an acute GI bleed. A CMP can be helpful, comprehensive metabolic panel, when looking at things like electrolyte function and renal function and liver enzymes, especially when you're kind of unsure to the cause or the etiology of your acute abdominal pain. And then in the emergency room, if they had this patient presenting in the ER, they would probably obtain blood cultures prior to getting any of these other labs in case they needed it. They often wouldn't run blood cultures unless if they thought a patient had sepsis, so infection in the blood. And then obviously any female of childbearing age with abdominal pain, you would want to get a pregnancy test and rule out pregnancy. Always, 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 always rule out pregnancy. Another interesting aspect was we got a UA, and a UA can be important in an acute abdominal process because you can find things like pyuria with appendicitis, and so as well as with diverticulitis. So it was important for us to get a urinalysis to make sure that we weren't seeing some type of worsening of the diverticulitis or rupture, leading to potentially fecal matter being absorbed into the urine or seen in the urine. So urine culture, typically you can see it will help you distinguish sterile pyuria due to inflammation, due to some type of infection from a fistula. So this can be helpful in sussing out your degree of severity of something like diverticulitis. And lastly, what was that palpable mass? In this case, we were actually able to palpate the abscess. And so it's not often that you'll actually palpate an abscess with diverticulitis, even though an abscess formation is fairly common in patients that have diverticulitis, but you often won't be able to palpate it. So about 20% of the time you can palpate it. It just depends on the location. So for our patients, thinking about how significant was their condition, we're always asking in any type of acute scenario, is this a stable patient for outpatient management, or do they need inpatient management? And this is your sick versus not sick conversation. This patient is sick. They need management imaging workup today, but do they need to go to the emergency department? And that's where our imaging can help us classify. And there's a Hinchey classification that can help with diverticulitis. And so these are things that I didn't know off the top of my head, so I looked them up. So again, anytime that you're dealing with patients in an acute or chronic nature, feel free to use your resources. So if we look at our patient, they did have an abscess that was present, but it was a confined pericolic abscess. So they are in stage 1B. So they are the most severe stage 1, but they are not in stage 2. So they are not having a pelvic distinct intra-abdominal or retroperitoneal abscess. So stage 1, this matters later on when we get to management, but just so you have some pictures to see kind of what is stage 1 versus stage 2. Stage 1 diverticulitis, you see that the small abscess is confined to that pericolic or mesenteric space. But in stage 2, the abscess is expanded and it's now extending into the pelvis or intra-abdominal cavity. Then obviously in stage 3, you're seeing actual discharge, gaseous release and rupture, and stage 4, you're seeing fecal discharge. So that's your most severe stages. Anything above stage 1 would need to go to the hospital for inpatient therapy. Now, in an outpatient setting, are you going to have access to a CT on site? Likely not. So your options are going to be, if you have outpatient imaging, you could send a patient to get an acute outpatient image done at an imaging center if you're able to get them there in time, or you're going to be sending them to an urgent care or ER to get acute or stat imaging. So likely this patient, if you're unable to get them outpatient imaging, if your shift is in the evening, or if you're maybe in a rural area and that just doesn't exist for you, you likely would send this patient to the emergency room for workup and management. So anyway, so we've identified that our patient is stage 1. So what is our management going to look like? And there's this I have this little table, and this is from a Medscape article, but Up to Date does a really great job of talking about inpatient versus outpatient criteria. And so if we're also, besides the stages, if you look at inpatient criteria for management of diverticulitis, you can see that there's some other reasons that we would consider having a patient be an inpatient patient. If they had signs of sepsis, so a systemic infection, perforation, immunosuppression. So this patient did have diabetes, but is it poorly controlled? Are they on high-dose steroids? A high fever, so above 102, significant leukocytosis. We're talking white blood cells in the 19 range, not 12, mild leukocytosis. Signs of peritonitis, really elderly patients, comorbidities. They aren't able to tolerate oral fluids, so they might be dehydrated, non-compliant, or they've already failed outpatient treatment. Those would be reasons you would send someone to get inpatient treatment that day. Otherwise, our patient fits into this outpatient category. And so the initial outpatient care for any diverticulitis, now this isn't diverticulosis, is oral antibiotics. And there's several different regimens here on Up to Date. It typically does involve multiple antibiotics, unless if you're using something like Augmentin. And I typically follow the recommendations pretty straightforward here. The diet for diverticulitis is a diet that you give anyone who has an acute abdomen. So very simple foods and fluids. Obviously, you start with fever, you feed a cold. So a very modified diet with moving back into eating normal foods. And there are, in diverticulosis and prevention, there are some foods that you'd want to avoid, which we can talk more about on Tuesday. And then you really need to have close follow-up for these patients. So patients that don't improve after 2 to 3 days of oral antibiotic therapy are patients that would then need to go inpatient for treatment. So, but patients who after a couple days have improved significantly with symptoms, their fever is down, those patients don't need repeat imaging. You could just follow up with them in office after the completion of their antibiotic therapy to talk about prevention. So really important with this case, this is a great example of sick versus not sick and kind of how to make that decision of when you would admit someone or not, or send them to get further workup or treatment. This is a patient who is sick, who could be safely managed, at least initially, outpatient prior to then wanting to move into more significant treatments later on. So I hope this was helpful for you guys. We can talk more about prevention of diverticulitis on Tuesday, but I wanted to go through some of the salient pieces here. And like you said, reach out if there's questions or concerns that come up in the meantime. Thanks.